So we start. Somebody can stop me in between if feels so. Okay. So uh, this patient, like you see ERCP image. Obviously, you are seeing ERCP scope. Then you are seeing cholangiogram, and you are seeing pancreatogram. So whenever you see ERCP, very important to whenever you interpret any radiology, first you have to name the investigation and then positive findings. One small point which is not relevant here, but always that you should see beyond the covered screen, sometime in the blank area, sometime in the beyond the area of interest. Also, there are very important findings. As we go, I will show you somewhere. Okay, sometimes what happens that you have done chest X-ray and there is a calcification lying in axilla. Okay, so that should not be missed. That some calcification or abdominal X-ray and there is a calcification lying at the in the inguinal areas. So that should be very important. So coming back to this study, so this study is obviously this is a scope, this is cholangiogram, and this is pancreatogram. So you have to recognize which is bile duct and which is pancreatic duct. Most of the time it is pretty easy, but rule of thumb is when you are teaching in when you are doing a scopy in short scope position. This is the short scope position. So in which the duct, if it crosses before crossing the vertebra, so then it should be the bile duct. So here what you see, this duct is crossing the scope and then crossing the vertebra, and the branching pattern you have to see it. If it is acute angle branching, then it should be bile duct, and if there is uh, right angle branching, then it can be pancreatic duct. So here what exactly what this patient has been this film has been put is, this is basically to show you the long common channel. Okay, so this is the area where you are seeing that bile duct and pancreatic duct are separating. Pancreatic duct is reasonably regular in outline, dividing, tapering. It looks normally, and here you see carefully there is pancreatic duct going, and this. There are two types of configuration described. If you don't remember, no problem. B on P and P on B. So which is the dominant duct, and then it is joining. The criteria of different people have taken different criteria. Most commonly, it's taken 11 or 12 millimeter more than that. So they can taken as long common channel. But secondary criteria is more important, that the duct, if the common channel is ectatic, so then it will be long common channel. And long common channel has got certain association, like carcinoma gallbladder, it has a very strong association. So here what you are seeing is seeing a filling defect, crescentic filling defect, and here you are seeing a stricture. So this was actually a case of carcinoma gallbladder, but no guesses for recording this one. But the lower long common channel is also very important, because treatment little will it will be depend on that. So this is another patient, second patient. So again, cholangiopancreato. So again, cholangiopancreatogram. So what you are seeing here again, this duct is crossing scope and then bifurcating at acute angle. So this is bile duct, and here you are seeing a faintly opacified duct, and then there is densely opacified duct. This is actually an uncinate process branch of the pancreatic duct. This is the main pancreatic duct. Subsequent during course, the main pancreatic duct has been opacified fully, and you see the dorsal duct branch. Normally, you remember duct of Hershey and then the duct of Santorni, and the two join. So, in chronic pancreatitis, it is possible that this duct can be very prominent. And sometimes what happens that during the MRCP examination, it will be reported as division. So that is one of the fallacy of MRCP, that division will be reported, but actually you can see that on a was actually reported as division, but this is not pancreatic division. This is chronic pancreatitis with dilated duct. And here you see carefully there is a filling defect. So when you interpret pancreatogram, you interpret based on the diameter. So all of you remember the diameter of main pancreatic duct is 3 millimeter in head, 2 millimeter in body, and 1 millimeter in the tail region. So you should remember. So here you don't see a scale, but because this has been cropped, but you will always have a scale by the side in the digital radiology. So anything can be magnified or reduced in size. So either otherwise you have an internal reference always, because this scope serves as an internal reference. So scope diameter is taken as 12 millimeter because most scope 11.5 to 12.5 millimeter. So 12 we take as internal reference and we compare with this scope. So that you will see. So cholangiogram essentially appears to be normal. The dorsal duct is very prominent, and the ventral duct is also dilated and shows filling defect. And we also try to see regularity of the main duct and irregularity of the. If you remember the classification of the ductal changes, then the side branch Cambridge classification, then side branch irregularity and main duct irregularity, depending on that we classify. So this shows main duct which is pretty irregular out here. You can make out, and uh, there is possibly some stricture out in the short stricture in the head region. A stricture you virtually always diagnose by upstream dilatation, and the narrow diameter is actually the secondary criteria. Primary criteria will be the upstream dilatation. So you always, whenever you see dilated duct, you will start searching for a stricture downstream. So in this patient, obviously, what you do with the stricture, you always dilate the stricture and put a stents. And most of the time 10 French is taken as pancreatic uh, pancreatic placed to a stent. So in this patient is optimum time to another case of pancreatic duct which is appears to be almost 10 millimeter plus, because here you have a scope millimeter and then lots of circulation here, and like you see plica circularis in a small way, like that you see single 10 French stent has been placed. Most of the time on ERCP, you can ERCP films, you can make out whether this is 7 French or 10 French stent by comparing the size of the stent with the scope and also configuration of a stent. So here you see the flaps of the stent. So this is typical pancreatic stent, 10 French diameter, which has been placed in the pancreatic duct. So this is same patient actually. So what you are seeing, interestingly, that PD has been tackled, but what then we have conlated the CVD, and CVD, what you are seeing is seeing there is a stricture in lower third. Whenever you see a stricture, you try to see whether this is centric or eccentric. So here you see centric stricture because it is tapering from this side and tapering from this side also. And this is a smooth, big-like tapering. So there is no soldering. Soldering means if it overhangs like this and goes like this, I will show you subsequently, then it tends to be malignant stricture. And in the stricture segment, you try to look for mucosal destruction. So here you see the mucosa is very smooth. So it has all the properties of a benign stricture, benign biliary stricture. And because it is in the lower third, the commonest region of lower third stricture will be chronic pancreatitis. And here you are seeing a stent in pancreatic duct. So obviously this is case of chronic pancreatitis. So this patient had pancreatic ductal stricture in the head region as well as biliary stricture in the lower CVD. So again, what will you do for pancreatic duct? I told you that 10 French is generally what ESG recommends. But many people now go for 14 French or even 17 French in the pancreatic duct, particularly when pancreatic duct is dilated. For bile duct benign biliary strictures, most of the time the target diameter is 27 to 30 French. but that will not be achieved in first session because that will lead to extreme pain in the patient. So first we place 10 French or 14 French or 17 French, so mainly 1 or 2 stent, and then subsequent sessions it will be upgraded to 27 or 30 French. So that will be done in patients. So this is again patient who had presented with 4 years for pain abdomen and raised LFOS. And again, what you see here is again you see here a stricture in lower third. Okay, so again a stricture in lower third. This was also a case of a characteristic wise which we discussed just now. So this is showing a characteristic of benign biliary stricture. Here for a change, it is there has been metal stent which has been placed. So you are seeing it is a mesh stent. So most of the time we use Boston Scientific stents. So this is the covered stent which has been placed here in the bile duct. So one should be able to make out. So what here see, whenever we start ERCP, it is always recommended that one should take film before injecting any amount of contrast. So that will show there is any calcification in the head region. So here you are seeing radio opacity. So there is calcification in the head region. Subsequently, contrast has been placed, injected, and that is taking irregular space, taking some sort of duct appearance, but it is not going up because of changes of chronic pancreatitis. So with further injection, the duct got opacified, upper stream ducts are dilated, but again this irregular filling defects. So these are basically calculi lying in the head region. So again we have dilated that, and across that we have placed a stent across that. So that should always be bridging the stricture, and if there are multiple stricture, ideal situation should be that all the strictures should be bridged. So whole pancreatogram, it is important to uh, take pancreatogram of the whole. Now this patient presented with painless jaundice for 2 months, and what you are seeing here, that lower duct is, again this is bile duct because it is branching at acute angle. It is crossing the duct. It is going by the side of the spine. So that is how you recognize the bile duct. So pancreatic duct we have not specified, and bile duct what is showing? It is showing a stricture in the middle of CVD. The cystic duct is not specified here, and then we have right branch and left branch which are all dilated but not much of irregularity. And then what we are seeing here, that you are seeing two dots. So which is this accessory? So this is combo cath or biliary brush. So this biliary brush, we will take brushings, and then it is very important that we take out the brush only after crossing the stricture, and it should not be opened below the stricture or inside the stricture, because there will be formation of false track and there can be perforation of bile duct. Bile duct is very much prone for perforation because there is very thin layer of muscle in the bile duct. So it is not a very strong structure. And what you are seeing here, that we have placed two stents in the bile duct, and here what you are seeing, actually you are seeing tip of the combo catheter, and here you are seeing the brush. So you know that it is not taking the path of the wire. So you can imagine that if you open lower down, then it can actually can cause false tracking and perforation. So here we are taking brush, and subsequently the two stents have been placed. So this patient presented with painless jaundice, and again what you are seeing now, you are conversant that it is showing characteristic of benign biliary stricture involving lower and middle part. So whenever you see this, either chronic pancreatitis or in this era, you can also have IG4 related disease. So you see other sites carefully. So if you have multiple stricture, IG4 will be more likely, but here we don't have anything else. So chronic calcific pancreatitis. So what you are seeing here, again, what we described, that this is ERCP image, cholangiogram, pancreatogram has not been obtained, it is not injected, so contrast has been injected. when we are doing for a stone, it is very important that we pass the catheter intrahepatic and start injecting from above. Why? Because if you start injecting from below, the stone tends to get pushed intrahepatic. And the second precaution one should take, that contrast should be diluted contrast. So it should be diluted to one third, diluted with one third of the saline, one third of the volume of the contrast, or up to half of the volume. So if you give very dense, then like in this patient, you are seeing that there appears to be no filling defect. So that will be paradoxical, but the CBD appears prominent considering this 12 millimeter. This appears to be around 8 9 millimeter. So paradoxical. Subsequently, we have done, we have passed a stone extraction balloon. And remember that stone extraction balloons are different from dilatation balloon. So dilatation balloons will be tapering balloons where the extraction balloons will have a right angle shoulder so that they can bring the stone down. So here we have pushed this balloon up and there are 3 4 stones down. So normally we don't do extraction like that. So we bring down the stone one by one or one or two at a time, because if we pick up all the stones at a time, there is no force transmission and extraction will be difficult. But some odd situation where stones are very small, we have done full dilatation and we are comfortable, only then this type of all the stones we will pick in one go. So in this patient, so again what you are seeing is uh, here you see that we have gone into the this is the pancreatic duct and this is the bile duct. Okay, so pancreatic duct we have gone, and this is a structure which you are seeing is seeing dilatation balloon. There are different dilatation balloon. So this is dilatation balloon which has been filled with dilute contrast, and we are dilating with dilatation balloon. So balloon dilatation we are doing, and with that structure will open up, and then we will place the stent. So that is how it should be done. Again, what you are seeing here is very important. There are two guide wires which has been placed. Okay, so the our intention must be to place two pancreatic stent, two stents in the pancreatic duct, and if you and there is a radiopaque marker here. I will highlight you in subsequent study. That is very important. That should always be beyond pancreatic, beyond the stricture. So subsequently, a stent will be placed. So what are you seeing this here in the plain X-ray? I told you. So this X-ray you are seeing a metal stent. So this is a case of acute pancreatitis in ninth week. So you can easily guess. So what was the case? So it was case of necrotizing pancreatitis where walled off necrosis. One was drained using lamps. So this is lamps lying there. But before moving extra time, we will do pancreatogram to look for ductal disruption. And if there is ductal disruption, then we will do transpapillary stenting, and after some time we will remove the uh, lamps. So here what you are seeing, that guide wire is passed, there is very irregular and it is going through the lamps contrast. So this is basically duct is disrupted, and that is how the one is communicating, and then we will place a stent and then subsequently let it heal. And some of you can make a guess. So what is happening here? Here you are seeing the common bile duct by the criteria which we just discussed is going parallel to a spine, slightly oblique and parallel to a spine. So, and then it is dividing at acute angle. So this is common bile duct, and then you have a filling defect. So this is a stone. But what is happening? There is a sickle cell impression here. So this is called extrinsic impression. So imaginary circle, if you draw like that, complete space, and then center is outside the bile duct. So this is extrinsic impression, not intrinsic impression. Intrinsic, the center will lie in the wall of the bile duct. So what is this? This is actually Meniere's syndrome. So typically at the level of cystic duct, a large stone impacted there. Commonly we have a stone above that obstruction, but here in paradoxically we have a stone below that stricture, and there is impacted stone in the cystic duct. So it is extremely difficult to manage by only by ERCP. If we have to manage, we will require cholangioscopy and laser, and then we can break that stone and try to clear that. But here what we have, what has been done, that because of this stone, because patient was sick with, so then what you are seeing, acute pancreatitis in 11th week of illness. So this is the pancreatic duct, and there is irregular cavity which is getting filled. The main pancreatic duct doesn't appear to be dilated, so most likely acute pancreatitis, not acute and chronic pancreatitis. In acute and chronic, we will have the duct irregularity and ductal changes. So this is acute necrotizing pancreatitis with a necrotic cavity, and here we will uh, trying to point you out that whenever you try to do a stenting, you see this is guide wire VisiGlide, and VisiGlide, the tip will be very radio opaque. The same is true about HydraJag also, and then highly radio opaque tip is finishing here. But you see another very dense radio opaque marker out here. So what is this signify? Signifies that beyond that, the wire is tapering and becomes floppy. So when you are dilating a stricture, actually this radio opaque marker should be beyond the stricture segment, so that the floppy segment you are not using for dilatation purposes. So this should always be kept in mind if one is placing second, third stent or doing a stricture dilatation. That should be beyond that. And here you are again you are seeing a plain X-ray. What you are seeing, that you are seeing a catheter which has been placed into a cavity for drainage, and that is draining. And then pancreatogram we have cannulated, and then it is going into a cavity which appears to be large cavity. Okay, and then we have placed the whole of the guide wire, and then the radiopaque marker which I was telling, so that has been pushed into the cavity. So that is very important, because only then we will be able to push the stent. So that we have placed. So this is the same patient, and stent is being pushed, and it has reached up to the uh, mouth of the that cavity. So here what you are seeing is uh, bile duct is extremely angulated, and region for angulation is very clear. This is T tube. So this is post-operative patient which is undergoing ERCP, and there are filling defects in the CVD. Multiple filling defects out here. You can make out. So this was retained CVD stone, and there we have cannulated, and we have achieved intrahepatic position. And after that, we can remove the tube on table, or we can put a stent and subsequently ask our surgical colleague to remove that. So that is how it can be done. Here, because it was very kinked, so we decided to put two stents so that it straightens up, and we did a sweep. We removed the stone, and subsequently our surgeons removed this T tube. So that is how it will be managed. Now what you are seeing, multiple images. So this is very large. So this is 12 millimeters. So what it appears, almost 2 centimeter plus size filling defect, and longitudinally it is 3 centimeter plus. So these are by definition very large CVD stones and hugely dilated duct. So this will require some sort of lithotripsy. So lithotripsy, some sort of lithotripsy, they can be mechanical, can be electrohydraulic, can be laser lithotripsy, or it can be extracorporeal shock wave lithotripsy. For extracorporeal shock wave lithotripsy, most of the time we require nasobiliary drain, because that will help putting of contrast and localization under fluoroscopy. So with fluoroscopy, because these CBD stones are not radiopaque, so otherwise fluorolocalization will not work. So targeting will become difficult. So here the contrast will be put and it will be very visible, very clearly. So this is the stone, again another case. So pre ESWL, this is seen, and then after ESWL, you can see that it got fragmented, multiple fragments are lying. So in subsequent sessions, endoscopic papillary balloon dilatation can be done and these stones will be extracted. So that will become easy. Another case of huge multiple large CBD stone, and again this will require some sort of lithotripsy and before getting clearance. Again, very large size of a stone which is getting crushed by mechanical lithotripsy. So before doing mechanical lithotripsy, the cholangitis should subside, because in the setting of cholangitis, doing mechanical lithotripsy will be extremely difficult and risky, because of flare off. This you can make out that this is contrast swallow steady. This is very irregular. So this is neoesophagus, and you understand neoesophagus can be made of either gastric pull tube or it can be colonic interposition. So here it looks like a gastric pull-up has been done, but at the anastomotic side there is a stricture which is reasonably tortuous and reasonably long. Most of the anastomotic structures generally are short, so they are typical in anastomotic structure, and the ones which are uh, ischemic structures in a way, so they are long and tortuous. So this looks like more like ischemic anastomotic structures. So this is will be difficult to open, will require more number of sessions. So that is how it has been done. So this you can see there are multiple sols, multiple cystic lesions in the liver. So whenever there is cystic lesion, possibility of simple cyst or hydrated cyst can be considered, and these are 2, 3, 4, 5, and cyst. So that's the classification or WHO classification. So whenever such type of cyst appears, so then you should remember always the Garvey classification and WHO classification. And whenever you see cystic lesion, the other differential diagnosis will be abscess. So in the abscess, what happens? The walls will be saggy, irregular, and in the hydrated cyst, it will be always regular. And hydrated cyst, in most of the hydrated cysts except type 1 cyst will show internal septation. So we are here, you are able to see internal septation clearly. And if wall shows calcification, even slightest degree of calcification, like here you are seeing slight calcification, here you are seeing slight calcification, so that will suggest presence of hydrated cyst pretty strongly. As time passes, whole of the cyst wall can get classified, or even the whole of the lesion can get calcified. So they are different stages of hydrated cyst. So then what happens that some of the hydrated cyst ruptures, and then ruptures, then how do you identify? Not by the communication. Here you are able to see communication. Situation where you are able to see communication of the ruptured hydrated. Ruptured hydrated. So that is the really of them, and here you are in the lines obstructing, and the mid and upper CBD is dilated, and this is the cyst. So that should be always recognized. Biliary rupture should always be recognized. So this can be either PCD gram or T tube cholangiogram, because there are two drains. This was actually a T tube cholangiogram. So T-tube drainage has been done, and here you see that there is another PCD and there is a cavity inside the liver. This is the dome of the diaphragm. So the cavity, if it is a very regular cavity, then I just explained that it will be generally hydrated cavity. But if it is very, very irregular and irregular margin, so then it should be abscess. So this looks like an abscess cavity. And I don't know why this abscess has formed, because this patient has CBD stone and GB stone. So cholecystectomy has been done. Place a stent, and then we will clamp this, and then subsequently it will be removed. So that will be the procedure this patient is going to require. So in hydrated cyst with biliary communication, what you do, you do a sphincterotomy, large balloon dilatation, extraction of the balloon, and we drain the cavity. So what you are seeing here, it is huge cavity which is getting filled and with the irregular. This is called crumpled paper appearance, and the ducts are intrahepatic ducts are dilated and CVD is hugely dilated. And what you are seeing here is EPBD being done, and the membranes are at the hydrated cyst. And this is how hydrated cyst cavity will look like. So the margins are very smooth and regular. That is how it is distinguished from the abscess, which I told you will, and there are multiple doubters history which is seen. And this is another case of hydrated. So this is a hydrated cyst cavity, and here they are very rare filling defect. This is because of presence of lots of membrane which is lying in the uh, bile. Okay, so this and what you are, which I just told you, crumpled paper appearance. So you can make, when you crumple a newspaper, multiple crevices and curves will. So you can imagine there, and there you are seeing the stone extraction balloon, which with which we are trying to extract these membranes. So we are pulling out, and what we have here are lots of membrane which are coming out, and this is the hydrated cyst cavity which need to be evacuated, and subsequently we will place multiple stents in ruptured hydrated. Okay, so this is in multiple stages, as a stage procedure we do, and lots of uh, hydrated membrane being evacuated. So that you are seeing here. So it's the same image which has come. Again, hydrated cavity you are seeing. So here, interestingly, what you are seeing bile duct, you are seeing cystic duct, all right, and right and left, and then hydrated cavity. But interestingly, this is the dome of diaphragm, and what you are seeing is the contrast is entering into the pleural space. So this is what is this? This is hydrated with pleural rupture and biliary rupture. Both sides it has ruptured, and you are seeing that pleural space has been drained with a intercostal tube which is lying there. Drain into the cavity. So most of the anastomotic structure will be small, a very short segment. So this is short segment, not like the previous one which I showed you, which is was like ischemic structure. So that is how. This is very, very typical corrosive structure, because in corrosive structures, what you see, upper is dilated, then typical appearance of benign. I said you that benign will be a smooth tapering, and there will be very little mucosal destruction, but there can be pseudo diverticulum. So you need to understand recognize what is pseudodiaphragm and what is mucosal destruction and ulceration. That mucosal ulceration will be very irregular and pseudodiaphragms are very regular and wall will be smooth. So this is, and typically most of the time corrosive strictures will be relatively long stricture. So this is a long stricture. What happens that you need to measure for dilatation purposes, but when there is tight stricture, it can overestimate. So here this segment we know for sure that there is a stricture, but sometimes we measure like this from here to here, then possibly we will be overestimating. And whenever there is esophageal stricture, it is mandatory to evaluate a stomach, because there can be also another stricture in the antrum area. So here you are seeing there is stricture in esophagus and there is a stricture in antrum. So this is again antral stricture. This is also corrosive. So historically we knew, and the pseudodiaphragm which I was talking. So here you can see pseudodiaphragm 1, 2, 3, 4, possibly 5. So they are not ulceration, because ulcerations will be very irregular, and the pseudodiaphragm will be like diaphragm and the wall will be absolutely smooth. So that is how you make out. And then there is no evidence of soldering. In case of soldering, this will go like this and come like this. Okay, so that there will be apple core type of appearance, so which is not seen here. So sometimes, like here you see there is a esophageal stricture, and we have placed a metal stent for the esophageal stricture. So occasionally, even for benign stents, we place benign strictures. We place fully covered metal stents, and we remove after that. We go by the manufacturer's guideline, and currently the Valflex stent can be extracted up to 12 weeks as per the manufacturer's instruction. So we will try to remove the stent in 12 weeks. So one should be aware of that. So many times we see in abdominal TB, there are multiple changes. So there is always issue of distinction between T and Crohn's. So few features will favor TB and few features will favor Crohn's. So here I have listed what are the features which will favor TB. So ileocecal disease typically shows often necrotic and often calcification. Calcification is very important, slightly less highlighted in literature, but if present, it virtually goes in favor of TB very strongly. Omental and peritoneal thickening, mesenteric fat is uncommon, but mesenteric fat will be common in case of Crohn's disease. Abdominal cocoon can be present, and there can be solid involvement, organ involvement like hepatic sol and all. So that can be seen. So what you are seeing in CT scan here. So this is typically, this is transverse colon, and what you are seeing, there is lots of neural thing, a bit of so there is tendency to for fixation. But that on that criteria, you can think of that this is possibly Crohn's disease. But also see here, it is involvement of the terminal ileum, which is thickened, and there are lots of narrowing of terminal ileum, because proximal to that there is fecalization. Fecalization will always suggest that there is a stricture out here. So there is ileal involvement, there is cecal involvement, cecum ascending colon involvement, there is thickening. So this is case of tuberculosis. So this is how it is seen. Again, terminal ileum, cecum, whole of the cecum is involved, ascending colon involved, and going up to even up to hepatic flexure. So this is terminal ileum and the proximal ileum, and this is you are seeing the fold thickening out here. So here this is CT angiography study, and then what you are seeing is IC valve. So IC valve is very clearly seen, and what you see here, that cecum is well distended out here. So cecum is not contracted. The plica circularis, Hostra, yeah, as you understand that Hostra, you make distinction between Hostra and plica circularis. So plica circularis are seen in small vowel and Hostra are seen in large vowel. So large vowel Hostra are always incomplete, generally covering up to 1/3 of the wall, and the plica circularis are complete folds. So it covers whole length of the small vowel. So it will go through and through. But in the colon, there is one hostra which is complete, going from one wall to other, and that is at the level of ileocecal wall. So here you see go right from medial and this triangular. So what happens in gaping iliac valve? There is the triangle of the ileum. Apex is towards the lateral wall of cecum, and in case of gaping, this will reverse. The base will be here, and the apex will be towards the ileal side. So that is what we say gaping iliac valve. That is how the appearance will be. So one should remember that. In Crohn's disease, what happens? There will be circumferential symmetric wall thickening of terminal ileum and ileocecal junction with involvement of terminal ileum more than the cecum. So that makes the distinction. Wall will show homogeneous enhancement or stratification. There will be peri-enteric fat, especially along the mesenteric fat. So mesenteric fat proliferation will be a sign. There will be abscesses and fistula and prominent mesenteric vasculature giving rise to comb sign, and there will be a small mesenteric lymph node. Mesenteric node will be more prominent in case of. So here you are seeing colonic involvement, and what you are seeing homogeneous enhancement. So that is very important. So homogeneous enhancements, and here you are seeing very prominent amount of fat, because fat will be always seen as black. So very prominent amount of fat you are seeing in this area. So everything will look clear because of fat. So that it is a case of Crohn's disease. So this is typical teaching TB versus Crohn's. So site of involvement, cecum will be more than ileum. In case of TB, Crohn's disease will be reverse. Ileum will be more involved than cecum. Length of involvement will be shorter in case of TB and longer in case of Crohn's disease. The right colonic involvement is 83% in case of TB and only 33% in case of Crohn's disease. Left colonic involvement in CD will be seen in 1/4. In TB, it is extremely uncommon. And the patulous IC valve, how do you recognize? I explained to you already. So that will be seen in homogeneous in TB and stratified in case of Crohn's disease, and mural stratified seen in less than 10% of cases where it's common in Crohn's disease. Mesenteric abscess very rare and may be seen in Crohn's disease. Calcification, I told you that not highlighted in literature, but it is very important to look for calcification, and calcification goes very strongly in favor of TB. So then mesenteric changes goes more in favor of Crohn's disease because it will be seen in virtually all patients, but will seen only 1/3 of the patients, and nodes will be large necrotic, and if there is calcification, that will help goes in favor of TB. A site is only fat changes and visceral fat, those should be looked for when we are seeing. So now we come back to again liver swell. So what you are seeing here is large uh, we have cystic lot and mostly detached membrane which seem to fit in. So again for difference hydrated cyst, and I told you that we always look biliary. So here we see that there is no intrahepatic duct dilatation. The bile duct doesn't seem to be dilated out here. So there is no evidence, overt evidence of overt rupture. So that we will try to see. And then we are seeing this, what we are seeing, this is stomach, this is liver, and what we are seeing in the towards the lesser curvature of stomach, we have a sol, and this sol appears to be relatively fluid filled, so cystic cavity. So obviously in this area the commonest lesion will be walled off pancreatic necrosis. But interestingly, what we see here is a very dense structure inside, that there are actually two dense structures which seem to be communicating with each other, and its enhancement pattern is comparable. And whenever you see dense structure, you always compare with the aorta or any of the arteries in around. So what we have here is a is SMA. So how do you make a distinction between SMA and CA? That you should know that SMA or arises from aorta. So SMA is arising from aorta, and then it runs for some distance parallel to aorta. And artery will always have a fat around it, and whereas veins may or may not have fat. So this is the SMV, which always looks bigger compared to SMA, and SMA will run parallel to. So because it is coming in multiple cuts, so this is SMA. So either you compare the enhancement pattern from the aorta or SMA, and you see that. So it is comparable. So this is some sort of arterial enhancement. So this is actually a pseudoaneurysm inside a vein. So one with pseudoaneurysm. So that should be always clearly understood. And what you see here, here is a, you have a different content. Here you have a hypodense content. So there is a pseudoaneurysm which is partially thrombosed. So this is not enhancing because less dense clot out there. So this is partially thrombosed pseudoaneurysm lying in there. And if you are good at it, you can make out from which cell is it is arising. It is arising from the splenic artery. So for that. So the same thing, the enhancement, and there are saw, and there is a evidence of thrombus. So you are seeing in a child or infant, and then you are seeing dilated stomach and dilated duodenum. So this is what is called typically double bubble sign. So all of us have read about differential diagnosis for this. This can be like atresia, duodenal atresia, or some compression. Because of that, there can be even in-law pancreas and all, but those are less likely. Most commonly, it is atresia. So this is barium swallow study. So a study should always be named. So this is barium swallow study showing a narrowing in cervical region, and sometimes it shows jet effect. Maybe subsequently we have some films. So this is cervical esophageal web. So it is showing jet effect. You are seeing very clearly. Jet effects suggest very significant narrowing, and because jet effect will always let you identify the exact segment of narrowing. So this is very narrow segment. So webs will always be only one few millimeter in thickness. In contrast, rings will be wider and strictures will be further wider. So that is how we make a distinction between. So this is webs can be single or multiple, that has to be realized. So this is a single web which is seen in this patient. Sometimes there are multiple waves. So this is slightly more difficult, but this is exactly what we saw in CT scan. So you are seeing ileum, and then you have a cecum which is well distended, and there is narrowing at ileocecal junction. So ileocecal strictures and ileum which appears to be very irregular. Okay, so these are irregular and speculated because of the ulceration. And then you have uh, another segment of a small vowel which is showing a smooth margin along the mesenteric wall, but anti-mesenteric border is grossly irregular and sends into multiple pouches. So this was a case of Crohn's disease, and you can make out multiple sites of obstruction. So stricture dilatation, stricture dilatation. So this is typical Crohn's changes which is seen. The mesenteric border is okay relatively, and then anti-mesenteric lots of ulceration, and ileocecal valve there is narrowing, but triangular shape of the ileocecal region is preserved. The cecum is not contracted. So typical what we read as signs of uh, Crohn's disease. So here, what here we see? What do we see here? This is gastric plain X-ray abdomen, and this is supine film. Why is supine film? Because we are not seeing any air fluid level. And for you, one should always remember that for toxic colon and gas pattern of the small bowel or large bowel, we always ask for the supine film. And for air fluid level and for seeing pneumoperitoneum, we always ask for erect film. So this is supine film. Here we are seeing stomach and another transverse gas filled structure. So this is transverse colon. Normally, transverse colon should show lots of ostration. Here we are not seeing, and if you measure the diameter, so it has been cropped. So here was the scale. So it is more than 5.5 centimeters. So that is the current definition for megacolon, toxic megacolon. So in toxic megacolon, the diameter, maximum diameter of transverse colon should be more than 5.5 centimeter, and the hostra should be effaced. So no hostra should be seen. So both parameters are filled here. So it is toxic megacolon. But there is also one thing which has been described in literature, that if you see lots of mucosal islands, either in the transverse colon, descending colon, sigmoid colon, then that generally signifies poor prognosis. So what you are seeing here, these small whitish structures, so these are actually mucosal islands. Okay. So not only toxic colon in this patient, but also mucosal islands. So toxic colon, anybody will be able to pick up, but one should be picking these mucosal islands because this signifies poor prognosis. So again, toxic colon only. So again, what we are seeing here. So what you are seeing here is a IVC, and this is aorta, this is stomach, and this is spleen. Spleen appears to be little enlarged, and this is one of the vessels. We can see whether this is a splenic vein or what. So that subsequent films we can see. So, but we see some of the lots of vessels here in the wall, more than normal. So we will like to watch whether there is any evidence of portal hypertension. So what we are seeing there, we are seeing a lease of vessels out here. So there's some sort of collaterals. So lots of collaterals lying at the splenic hilum. So another thick collateral you are seeing going towards liver from splenic hilum. So this is one collateral vessel which is going in towards the stomach, and this you are seeing as a splenic vein. So splenoportal axis appears to be patent because splenic vein thrombosis or portal vein thrombosis will be one of the reasons for portal hypertension. Okay. But interestingly, more than that, you are seeing a structure here which is very densely opacified, and opacification again is comparable to aorta. So this is again pseudoaneurysm, which is arising from the splenic artery, and there is a splenomegaly because of that, and there is a calcification inside the spleen, and this is splenic artery. So there is evidence of portal hypertension. There is evidence of pseudoaneurysm in the splenic artery. So that is seen there. So might be that is pressing the duct. So this is hydrated, which I think we have seen. This has come second time, and this is showing. Uh, this is showing a cystic lesion. Where it is showing cystic lesion? So I told you there is only one vessel which runs parallel to aorta, and that is SMA. So you are seeing origin of SMA, then SMA going here. And whenever you are seeing SMA, whatever seen anterior to that, that is generally pancreas. So you are seeing a cystic soil in the pancreas. But sometimes what happens that if you see such a cystic soil, it is touching a stomach, it is touching one of the bowel. So it can be rising from a stomach, or it is can rising from the bowel. So how do you make a distinction? And so for making distinction, what happening to the vessels around, so that comes in, that helps us in the differential diagnosis. So if you see carefully, so try to look for those vessels. So what is happening? This is a splenic vein, which is not lifted, which is pushed posteriorly. So this is possibly arising from a structure anterior to a splenic vein. So anterior to a splenic vein will be pancreas only. And then what is happening that is this is getting splayed. So this is arising from pancreas, not from the stomach and not from the adjoining bowel wall. So that is how we decide the origin of any soft tissue lesion. So this is CT scan film of the stomach. This is the stomach is grossly dilated, as you can see, and this is basically food residue. So this is not the lesion which we are seeing, the culprit lesion here. So whenever there is stomach is dilated, we try to see for the antral area, and what we see here, there is antral, lots of thickening and standing around the antral area. And what you are seeing actually here is actually a soldering. So this is air in duodenum, which is standing, and this is hanging inside. So this is hanging like that. So this is CT counterpart of what we see as soldering in barium study. So this is basically carcinoma stomach, and you see little bit of fluid around this area. So possibly there is peritoneal spread in case of uh, carcinoma stomach. So you can see the portal vein is patent, and then lots of food residue, and this is the mural thickening, and this is the soldering which I was pointing you out. So this is case of ecclesia cardia. So that it is very important to realize that most of the cases of ecclesia cardia, the stricture will go below the dome of diaphragm. So here you are seeing dome of diaphragm. Most of the time in ecclesia cardia, this gastric air bubble is absent. So that should be pointed out, but here it is present. So it is not in 100% of the patients, or this study might have been done after intervention or balloon dilatation. And this structure, and there should be no mucosal destruction. So that mucosa appears pretty smooth out here. But there is always differential diagnosis of secondary ecclesia. So most of the time, secondary ecclesia tend to go above the dome of diaphragm, and there will be evidence of mucosal destruction in this segment. and the stomach which will be filled will show the polypoidal filling defects because of malignant lesion out there, and dilatation is more in case of eclasia. So more than 5 centimeter, it is highly suggestive of primary eclasia cardia rather than secondary eclasia. So I think I will leave it at here. This should be the last film, and then another day we will take another class. So here again in the pancreatic region, we are seeing a large saw, and there is a vessel. So this is obviously a splenic vein which is going. So whenever we see describe pancreas, so we should always describe for the vessel around it. So a splenic vein, a splenic artery, portal vein, SMV, that should be described. But here it is very important to realize that these black structures are what? These are basically air. So whenever there is collection, when there is you see air inside a collection, there is always possibility of infection. So this is possibly one which is infected and because contains air, or there is bowel fistulation. And here we see lots of vessels out here. So some degree of portal hypertension this patient is developing. So possibly a splenic vein thrombosis. So splenic vein is here seen, but subsequently it is not seen anywhere. So possibly a splenic vein thrombosis. Here also you are seeing extra vessels. Here also multiple vessels. Here multiple vessels. So possibly portal hypertension, and here, but you are able to see the SMV, and subsequently possibly portal vein also we will see. So possibly thrombosis only. So we will stop here today, and we can cover rest of things. There are lots of things which we can consider. We will take later on because it's already past 70 minutes. Okay. Thank you.
Mm. Thank you. Please share the links for the other classes as well,
Any
sir, because
questions? Then we can.
exams are ahead, sir.